Hi, my name is Christy Malakas. I'm the Pharmacy Administrator at Magruder Hospital in Port Clinton, Ohio. Today I'm going to be talking to you about 340B for the Pharmacy Technician. And to give you a little more information about Magruder Hospital, we are a small critical access facility. We have 25 beds and we have an emergency room, oncology department, ICU, surgery, and we're on the banks of Lake Erie in Port Clinton, Ohio. The objectives of the program today are to talk about the model of 340B and to understand what makes a patient, a program, and a covered entity all eligible. We're also going to explain the process for using contract pharmacies, describe how we audit and make sure that 340B is in compliance. We're going to talk about what to do if you have questions or need assistance and what some of those resources are available to help you for 340B. And then finally, we're going to describe the role of how pharmacy technicians can play as 340B program coordinators. To give you a little bit more background on the 340B program, it's a federal program that requires manufacturers of drugs to provide certain covered entities with significantly reduced prices on drugs, but these are only eligible for outpatient prescriptions. So that's the important thing to remember there. It's certain covered entities that we'll talk about in a minute and outpatient drugs. The purpose of this was to make use of scarce federal funds and to stretch them as far as possible so that it could reach more patients that could benefit more, as well as healthcare organizations. 340B was created in 1992. It got its name because it was Section 340B of the Public Health Service Act. So it's operated by three areas. It's the Department of Health and Human Services, and underneath that is HRSA, or the Health Resources and Services Administration. This is who conducts the audits. The Office of the Pharmacy Affairs of HRSA, or OPA, is who manages the registration website that you'll hear me reference in the next few slides. So how does 340B work? It first starts with the manufacturer. They're going to calculate the 340B price. The covered entity then will purchase the drug for patients that are eligible at that discounted price, and then the patient will receive the 340B drug. Sounds really easy. There's a lot of fine workings within that nice three-part matrix here that we'll get into a little bit more. So let's first start with the manufacturers. If a manufacturer is going to participate in Medicaid, they're required to charge a price that will not exceed that ceiling price for 340B, and they have to sign what's called a pharmaceutical pricing agreement, or a PPA. That's a condition to participate in Medicaid, so of course all manufacturers are going to do that. Manufacturers can be audited by HRSA, and what will happen is, and you may have seen this in the news, or if you work for a hospital, you may have seen this from specific manufacturers, is that they'll come back and say, these manufacturers overcharged you for 340B pricing from the first quarter of 2013 through 2015, and now we'll give you a credit for that overcharging. That's where the audit comes in by HRSA. So it's very nice for the covered entity that it keeps the manufacturers in check. The 340B pricing is calculated quarterly based on the metrics supplied by Medicaid, and these are always a quarter behind. So if you have the first quarter of the year calculated, these won't be implemented until the second quarter. And the manufacturers, when they're calculating these prices, they can't exceed the ceiling price, but there's nothing that prevents them from charging below that. And that's where we see penny buys come in. Penny buys are very popular for 340B covered entities. This is just a snapshot of our software we use at Magruder and what a penny buy could look like. So when you check the penny buys, there's different ones offered by certain manufacturers, and you'll see specific drugs, and then you'll see your GPO pricing, your average wholesale price, and then you'll see the 340B price where it's dropped to a penny. So you can clearly see the savings there, and you can pick those up for a penny if you need them. They're not always medications that are popular, but a lot of times it's things that certain covered entities can use, and those penny buys come in handy. So we talked about the manufacturing side. Now let's move into the covered entity. What qualifies a covered entity to be 340B? They have to be a nonprofit healthcare, and they have to have a specific federal designation. To have that federal designation means they get specific funding, and once you've got that established, you then have to register on the OPA website during the enrollment periods. So again, we're back to that quarter behind. So if you register in January 1st through the 15th, you aren't 340B eligible until the second quarter start date of April 1st, and so on and so on. So you aren't technically a 340B even though you may qualify until you have registered on the OPA website, and that's always a check during all HRSA audits to make sure that all of your registration information on the OPA website is indeed correct. Some examples of covered entities that are 340B eligible would be specific health centers, Ryan White HIV and AIDS program grantees, certain specialized clinics, and then hospitals, and there's 6 specific categories of hospitals. The categories are children's hospitals, critical access hospitals, which will abbreviate CAH for the remainder of this presentation, disproportionate share hospitals, which you'll hear called DISH hospitals, freestanding cancer hospitals, rural referral centers, and then sole community hospitals. Disproportionate share hospitals serve a disproportionate number of low-income patients. So they've got a higher percentage of low-income patients than the average number of hospitals. They receive payments from CMS to cover those costs of providing care to uninsured patients. So if we look at 340B eligibility, there has to be a certain percentage of disproportionate met in order for you to become 340B eligible. For children's hospitals, disproportionate share, and freestanding cancer hospitals, it's greater than 11.75%. So you'll see hospitals monitoring this percentage constantly, making sure they don't fall below this number. They would fall then out of 340B eligibility. Rural referral centers and sole community hospitals only have to be at greater than 8%. And critical access hospitals don't have a disproportionate percentage that they have to meet at all. They are automatically eligible for 340B status. Now, GPO prohibition is something that applies to certain hospitals, and this is when a GPO is a group purchasing organization, and these are used for purchasing medications and actually other items in a lot of hospitals. GPOs cannot be used to purchase outpatient drugs for certain covered entities: children's hospitals, DISH hospitals, and freestanding cancer hospitals. To summarize the GPO prohibition, children's hospitals, DISH, and freestanding cancer hospitals are all affected by the GPO prohibition, which means they cannot use a GPO to purchase drugs for outpatient prescriptions. The last real restriction for covered entities is known as the orphan drug rule, and I titled the slide the original orphan drug rule because it has sort of changed a few times since the inception of the 340B program. But the ruling currently is that for specific hospitals, critical access, freestanding cancer, rural referral centers, and sole community hospitals, these select group of hospitals cannot purchase drugs at 340B pricing that would be used for an orphan drug indication. They can't buy orphan drugs if they're going to be given for that orphan drug indication. They can't buy orphan drugs at all. So it's gone back and forth on whether or not they can buy orphan drugs at 340B pricing if they're being used for a different indication. Currently that has been vacated, and the ruling currently now is just that they cannot purchase orphan drugs at all for 340B pricing. So to summarize, those affected by the orphan drug exclusion are critical access, freestanding cancer, rural referral centers, and sole community hospitals. Finally, the Medicaid discounts is an exclusion or inclusion that must be paid close attention to prevent any kind of diversion from happening. There's 2 things that a covered entity can decide one way or the other. One is to carve in, one is to carve out. If the covered entity is going to carve in, that means whenever they have Medicaid patients coming to their facility, they're going to purchase drugs for Medicaid patients through 340B. To carve out means they're going to purchase drugs for Medicaid patients through their other mechanism. If it's a critical access hospital, we're going to use GPO. If it's a DISH hospital, they're going to use their WAC program or another mechanism for purchasing drugs. The purpose of carving out is to prevent duplicate discounts or double dipping. And what that means is there are some states in the country, they're not all the same, that accept rebates on Medicaid patients. So if the hospital gets 340B benefits through Medicaid patients, and then the state also accepts rebates on Medicaid patients, that's essentially where we get the term double dipping or duplicate discounts. And HRSA considers that diversion, and upon an audit, that would create a finding. So most facilities choose to carve out to prevent any sort of duplicate discount or the potential therefore. So here's a discussion. As a critical access hospital, which of the following eligibility restrictions apply? Is it the orphan drug rule? Is it the disproportionate share? Or is it the GPO prohibition? Or is it all of those? I didn't give you letters, so your answer there is the orphan drug rule. That is the only restriction that applies to a critical access hospital. The disproportionate share and the GPO prohibition do not affect critical access hospital. Okay, so we've talked about manufacturers, we've talked about covered entities. Now let's talk about what makes a 340B drug eligible. It has to be an outpatient prescription, and OTC drugs are also eligible if there is a valid prescription. Insulin is included in that as well, and biologics, as long as they're dispensed with a prescription, obviously. But these can't include vaccines. So biologics, meaning those new medications for rheumatoid arthritis, blood products, as long as it's not a vaccine or considered a vaccine, it's eligible for 340B replenishment. So here's a discussion. Which of the following would not be an eligible 340B drug? A drug for an inpatient, a vaccine, Tylenol without a prescription. I guess I should specify the strength. Let's go with Tylenol 325 milligrams, or all of those. Okay, none of those prescriptions are eligible to be 340B. Inpatient drugs are never eligible, only outpatient. Vaccines are not eligible, and an OTC without a prescription is not eligible. Okay, so we've covered manufacturers, we covered the covered entities, and we've covered the drugs that are 340B eligible. The last thing are patients. What makes a patient eligible to receive 340B benefits? They have to have received healthcare services other than just drugs from that 340B covered entity, and those services have to be from a healthcare provider who is either employed or contracted by that covered entity. HRSA likes to use the word credentialed, so a credentialed provider, however the healthcare facility deems a provider is credentialed, that is what makes that service eligible for that patient. And the service has to be within the scope of practice, meaning an anesthesiologist can't write a prescription for an oncology drug or a chemotherapy. It has to be within that scope of practice. So, as a discussion, which of the following patients' medications could be replenished through 340B? Would it be a patient receiving medications in the emergency room of a critical access hospital? A patient who receives chemotherapy at an oncology clinic within the four walls of a DISH hospital? An inhaler for a patient whose length of stay is 3 days in a 340B facility? Or an antibiotic for a pre-op same-day surgery case at a critical access hospital? So if we look at each one of these, the first one, a patient's receiving medications in the ER, that's considered an outpatient, and a critical access hospital, that is 340B eligible. So we could replenish that through 340B. The second, a patient who receives chemotherapy at an oncology clinic at a DISH hospital, the four walls, meaning within the hospital, so that would be also an eligible prescription. The third, an inhaler for a patient with a 3-day length of stay. That's considered an inpatient prescription. Unless that medication is a discharge prescription and they're going home, we can't fill that prescription on 340B. The final, antibiotic for pre-op same-day surgery. The key word there, or keywords I guess, are same-day surgery. If that's considered outpatient at a critical access hospital, then you can fill that for 340B, replenishment. The next portion of this presentation talks about contract pharmacies, and this is when a 340B covered entity signs a contract with a local retail pharmacy in order to extend services or increase patient access to 340B savings. This is especially important or helpful for those entities that don't have an in-house pharmacy, outpatient pharmacy services. So how it works is the covered entity purchases drugs from their wholesaler. So let's say their wholesaler is McKesson, and they use what's called a ship-to, bill-to. So essentially the ship-to address is the retail pharmacy. The bill-to address is the hospital. So the hospital is going to pay for the drugs using their 340B discount, but the retail pharmacy actually receives the drugs directly. So the hospital never receives any of the drugs. The contract pharmacy can then supply all of those 340B drugs to patients who meet that same criteria we already established. The inventory is very specific. You can't reorder medications until an entire bottle is used, and that same NDC that we used to fill the first has to be used to replenish that same 340B drug. So how does it work from a finance side? Is the contract pharmacy will charge the hospital a negotiated dispensing fee for each prescription filled. These dispensing fees will vary between each retail chain, and the covered entity will receive a payment from the pharmacy. That payment is based on what the reimbursement is from the insurance company. So how the pharmacy and the covered entity benefit is that the covered entity can profit because the difference between the actual insurance and the cost of the drug could be substantial. So let's say a drug costs $5 on 340B benefits, but the insurance reimbursement is $200. After the dispensing fee that the pharmacy takes from the covered entity can still profit $150 on each drug, or whatever the dispensing fee may be. So the pharmacy is not required to offer those 340B benefits to patients, meaning they can still charge their regular price of their drugs to their patients. There's no requirement to offer a less price to their patients. So here's a nice confusing diagram of how this process works. So if we start over with the patients on the left-hand side, the patients establish that relationship with their covered entity, and that covered entity will then purchase drugs at the 340B price. The wholesaler will ship the drugs to the contract pharmacy, and that contract pharmacy dispenses the drug to the patients. If you look in the middle, the covered entity is paying the contract pharmacy the dispensing fee. The contract pharmacy is paying for the 340B drugs. Now remember, those 340B drugs are pretty cheap, and they're also getting that insurance reimbursement, and that's where the benefits lie from contract pharmacy. A lot of covered entities will work out a brand-only contract because that's where you see the largest margin in the difference between the price of a 340B brand drug and the reimbursement from insurance. You don't generally see as big of a margin from a generic. If you look at this chart, you can see the growth of contract pharmacies over the past just 2 years. So you can see the number of 340B entities that have contract pharmacies and the unique locations where those are, and the total number of contracts that have increased in just 2 years. So from 2013 to 2015, there's been almost a 6,000 total contract increase just in 2 years. And this is a nice graph from the Drug Channels Institute that breaks down the most volume by chain of who has those contracts Walgreens is the main holder of those contracts at 35%. Walmart, CVS, and Rite Aid are the next sort of big three there. And then Kroger and Safeway have a few. All the others are grouped into the independent, probably, and some of those smaller chains. Okay, so if you're like me, you're probably wondering, how the heck does all of this happen with no mistakes, 100% compliance, and no issues? Well, first of all, there are always some kind of issues, but the whole process is electronic, and there are companies and vendors that help manage both processes from the contract pharmacy and the in-house outpatient pharmacy side. So from a contract pharmacy side, the electronic side is that the entity will send the data feed to the vendor, meaning Joe Smith came to our oncology clinic and received 3 prescriptions. The patient goes to the contract pharmacy to fill those. So the pharmacy is going to submit that claim through the switch. The switch is where insurance adjudication takes place. So what happens is that third-party vendor will get that eligibility information sent back and determine whether or not that claim can get paid. The pharmacy will then get the reimbursement, and then they'll pay the covered entity the difference. The covered entity will pay the pharmacy dispensing fees, and then you can replenish those 340B drugs. It's a nice, confusing process, but the vendor and the third parties help make it a little bit easier. So the 340B vendors collect the data at the switch, and what they do is they match the patient information with what type of encounter it was from the covered entity, which means they're going to take Joe Smith's data from Walmart Pharmacy, look back at your hospital and say, okay, he was in your emergency room, that's an okay encounter, that's an outpatient type of visit. These prescriptions were written by a credentialed provider, and all of these are okay to be replenished under 340B eligibility status. The 340B vendor also monitors your inventory for when you need to reorder supply, and they help you with auditing processes through reports and making sure that you have everything you need. So the split billing software is used for hospitals or other organizations that have a drug order not for contract pharmacies, and this is used to split a drug order for inpatient items and outpatient items, and the outpatient items will then go into your 340B account. So what it does is it pulls in information the same as what you might find for the contract pharmacy, and it can tell, based on the data feeds pulling from your hospital, what is outpatient and what is inpatient. It can also build a virtual inventory of products. So let's say you were purchasing a specific chemotherapy item at 340B pricing, and then determined that that patient you were replenishing that drug for was actually a Medicaid patient. You can add that to your virtual inventory so you don't get 340B benefits later on, and that will sort of even out your 340B eligibility. It also can blacklist orphan drugs if you're affected by that orphan drug exclusion, which when you would enter in an orphan drug, it doesn't even allow you to purchase that at 340B pricing, so you don't need to worry about accidentally buying under 340B pricing. So auditing is a big part of the 340B program to ensure that you're in compliance. Both self-audits as well as independent outside audits are essential. The covered entity is responsible for that compliance, and not only for your internal program with your split billing and your outpatient, as well as if you have a contract pharmacy, you're required to maintain any auditable records for that contract pharmacy. One of the requirements with HRSA is that you conduct an annual audit performed by an independent outside auditor, so you sort of get a nice unbiased viewpoint of someone coming in and telling you what you can do better at. You can always do better at 340B. There's always questions and things, and that's where there's a lot of resources to help. One of them is the 340B Prime Vendor Program. This is managed by Apexis, and the Prime Vendor Program serves 3 roles, really. They help negotiate pricing, and they help establish distribution solutions that improve access to meds that are more affordable, and really they offer just different services. The biggest thing for me, and I've noticed for other 340B program coordinators, is that they offer just real-time help when you have questions. They have an online chat tool where you can go in and just, you don't have to say who you are, where you're from. You just say, I have a question about this, and they'll answer you or direct you to where you need to go, and it's very helpful. The other help that was a big help for me was 340B University. If you're interested at all in 340B, or if this is something that you're going to be getting more involved in with your job, this is a very intense 1 or 2 day training. It's free. You just have to find a way to get there, but they have them frequently, and it's managed by Apexis as well. But it is the most informational, intense 1 or 2 day session on 340B that you can imagine, and you'll learn a lot. From a pharmacy technician standpoint, the roles are expanding, and you might see now the 340B program coordinator role, which is being filled by pharmacy technicians, and it's a great expansion of pharmacy technician responsibilities. So some of the job description of this position is they'll have daily oversight of purchasing, reporting, and basic real-time monitoring of medications that are used for 340B. They'll complete the self-auditing requirements that we just talked about were so important and help maintain compliance. Managing the OPA website registration is very important, making sure you have the right address, the right names. If you have any additional sites that you need to list with your facility, it sounds really easy, but that's one of the most common findings on an audit done by HRSA, is an incorrect listing on the OPA registration. Active engagement and ongoing education of changes. The program is constantly changing about each quarter, so this is a very busy objective. And then finally, educating staff and administration on the impact of changes. So pharmacy really drives the 340B program, though a lot of it needs to be tied with your finance department. And so educating the CFO or the finance or accounting director is important, especially when it comes to the cost report or filing different financial reports during the year. As a conclusion, so 340B is complex, but there's a lot of resources available if you have questions. And it's really beneficial to take the time to learn it and to navigate through, especially if it's, number one, if it's an interest you have, number two, if it's going to be part of your job. Learning it as much as you can is essential to maintain compliance. And then compliance and doing those self-audits is important to help prevent diversions, and especially to have complete successful audits. Here are some references that might give you a little more information if you need it, and I thank you for your time.